Welcome. Pulmonary infections, particularly pneumonia. The pulmonary defense system are mainly two types. The innate or the natural immunity. Important is the mucus shield, which is continuously moving upward by the ciliary movement, which takes away the bacteria away and also foreign bodies. And neutrophils and macrophages and complement from the blood, which will be constantly being supplied, attack the bacteria directly without immune activation. And then adaptive immunity by secretion of specific antibodies and activated cells, IgA in the surface mucosa, IgG and IgM activated T lymphocytes, plasma cells, macrophages processing the antigens, bacteria, sending to the lymph node, and activated T lymphocytes coming into the blood, and they produce chemical mediators to stimulate macrophages, which efficiently remove the pathogens. So there is a complex defense system built in, which keeps the airway sterile. Now, pulmonary infections. Infections of the lungs are very common, including upper respiratory tract infections. They form the bread and butter of a GP practice. Very, very common. And I'm stressing on this point because you need to read this thoroughly. It will help you in every day of your professional practice. Now, pulmonary infections are many. Bronchitis, acute, chronic, bronchiolitis, bronchoalveolitis, bronchiectasis, lung abscess, pleural infection, pleuritis, but we will cover pneumonia, inflammation of alveoli primarily. Usually, pneumonias result from a primary viral infection which predisposes to bacterial overgrowth and then causing bacterial pneumonia. But viral pneumonias, bacterial pneumonias can occur separately. But this is genetic predisposition to infections or immunodeficiencies, diabetes, mid-88 mutations, IgA deficiency, splenectomy. All these patients are prone for severe pulmonary infections. Now, considering pneumonia, there are many different subtypes. So, etiologically, it can be infective pneumonias, bacterial, viral, fungal, common, or non-infective, toxins, chemicals. Morphologically, pneumonia inflammation may be limited to one lobe, known as lobar pneumonia, or multiple lobes, patchy involvement, known as bronchopneumonia, and inflammation limited to alveolar walls only, that's interstitial pneumonia. But more important clinically, community acquired and hospital acquired nosocomial pneumonias, typical and atypical pneumonias, acute and chronic pneumonias, and epidemic pneumonia legionella. So we'll go a little more detail on clinical types. Clinically commonest is the community acquired pneumonia, a healthy person in the community developing pneumonia. And these pneumonias are usually known as typical pneumonias because they present with the classic signs of fever, dyspnea, and consolidation. Bacterial community acquired pneumonia is the commonest, caused by Streptococcus pneumoniae, most common, but it can be caused by many other bacteria, but Haemophilus influenza is next one. Viral pneumonias, parainfluenza is common in children, but influenza A and B in adults. Now, hospital acquired, that is pneumonia developing in an otherwise diseased person or very young age or very elderly age. Pneumonias are characterized by gram-negative bacteria, Klebsiella, Serratia, E. coli, Pseudomonas. But it can also be caused by Streptococcus pneumoniae, but gram-negative bacteria are more common. Community acquired pneumonias are typically lobar, that is affecting part or full of one lobe only with the adjacent lobe not affected. Viral pneumonias and atypical pneumonias are characterized by interstitial inflammation, that is inflammation limited to alveolar wall without consolidation. Usually patients will have severe dyspnea but no consolidation. And hospital acquired pneumonias, patchy involvement in multiple lobes and also bilateral. Now, less common, chronic pneumonias, that is fungal pneumonias, Aspergillus candida, tuberculosis, and aspiration pneumonia, that is accidental aspiration of oral or gastric contents, mixed oral flora, growing, mostly anaerobic but also aerobic bacteria, and the necrotizing pneumonia and lung abscess starts with pulmonary infarction and secondary anaerobic growth. In immunocompromised, pneumonias are usually severe and by special pathogens, cytomegalovirus, pneumocystis in AIDS patients, candida, atypical mycobacteria in immunocompromised. Now we'll go detail of commonest. Community acquired are also known as typical lobar pneumonia. Usually healthy adults in community, middle age 20 to 50 years, males more common. 1 to 3 days of high fever, pleuritic chest pain, rusty sputum with severe dyspnea because the lung cannot absorb oxygen. It's full of inflammatory fluid. Usually unilateral, part or full lobe inflammation, usually without tissue destruction. Bacteria spread through alveolar pores of corn. Commonest pathogen is Streptococcus pneumoniae, rarely H. influenza, Moraxella, Klebsiella in otherwise diseased lung or aged patients, and chronic alcoholics. Lobar pneumonia has a classic 4 pathogenetic stages. Remember the inflammation, all the stages of inflammation occurring all over the lobe. So first day of vasodilatation, congestion, and edema fluid filling the alveoli, known as congestion phase. Second day is exudation. Plenty of RBCs are also released into the alveolar lumen. And this time the lung becomes red, heavy. So it looks like a liver. So it's known as red hepatization phase. And from third day, neutrophils come in, macrophages come in, they digest all the RBCs, and plenty of just neutrophils and then macrophages fill the alveolar spaces. At this stage, the involved lobe is gray and heavy, and that's why it's known as gray hepatization. And the next 4 days, there is clearing of all the neutrophils, macrophages, dead tissue, and finally, just few macrophages remain. That's back to normal, known as resolution phase. Complications usually rare because there is no much of tissue destruction. Occasionally, lung abscess, pleuritis, pleural effusion, even septicemias, pleural adhesions and fibrosis at the later stage can happen, rarely. I'm now showing gross images of red hepatization, gray hepatization, and the microscopic stages. So a normal lung, alveolar walls, alveolar pneumocytes, capillaries. Following exposure to bacteria, there is severe congestion, that is dilatation of the blood vessels, the first stage of inflammation, vasodilatation, and initial leakage of protein-rich fluid into the alveolar cavity. And there are macrophages which are normal, alveolar macrophages, and plenty of fluid. RBCs are still within the blood vessels. The next step is when the RBCs are released into the alveolar lumen, plenty of RBCs and few WBCs coming in, neutrophils. These are neutrophils and these are all RBCs. So plenty of RBCs, so it's known as red hepatization. And finally, the macrophages starts clearing, dead tissue is removed, and only WBCs, that is neutrophils and macrophages, remain. And this stage is known as gray hepatization because it won't be red anymore, it will be grayish. And the next 4 days, there is total clearing and return back to normal. No fluid and alveolar sacs are free. Just few macrophages remaining. That is resolution. So 4 phases: congestion, red hepatization, gray hepatization, and resolution. Okay. So few more gross images. Red hepatization phase of a lobar pneumonia. Note the inflammation is limited to the lobe because there is no tissue destruction. Bacteria are spreading from one alveolar to another alveolus only. No destruction. And cut section. So that's the normal lobe. in a smoker's lung, so it appears dark, but that's normal. And pneumonia, that is the consolidation of the lobe, which is grayish now. Redness is clearing. Now the second group is the hospital-acquired or nosocomial pneumonias. They are morphologically bronchopneumonias because there will be tissue destruction, bacteria spread from one lobe to another lobe by destroying the tissue. And mostly lower lobes are affected because the fluid settles down gravity. And this type of pneumonia is common in diseased lung or diseased persons or extremes of age, infants and very elderly, and usually in a hospital setting, but not necessarily all the time. The common organisms are all gram-negative bacilli, Haemophilus influenza, Klebsiella, Moraxella. Most common is H. influenza. Okay, next is Klebsiella. But also Streptococcus pneumoniae, which causes lobar pneumonia, can also cause bronchopneumonia in diseased persons. Okay. Now, patients present with high fever, rusty sputum, pleuritic chest pain, no clear stages are seen clinically like in lobar pneumonia because there is new patches developing, and one may be in red hepatization, another one in gray hepatization, another one in resolution. So mixture of all stages. So clinically, different phases are not easily distinguishable. Complications are more because there is more tissue destruction, so more chances of lung abscess, pleuritis, pleural effusion, fibrous scarring, irregular emphysema, scar emphysema. And I am showing one specimen of lung fixed, multiple patches of bronchopneumonia all over both the lobes, and there is tissue breakdown and a abscess. So gross specimen of a bronchopneumonia, plenty of consolidation patches in the lower lobes, less in the upper lobe compared to a normal lung. So now I'm comparing bronchopneumonia. There will be involved inflamed alveoli with normal alveoli, and in hypo overview you can see different stages. See, that's a fluid accumulated within the alveolus, so congestion phase, plenty of RBCs, red hepatization phase, and you can see here just WBCs, gray hepatization phase. Okay, so there will be multiple patches in the lower lobes bilaterally. So this is usually a secondary pneumonia in a aged or a sick patient. Both the genders are affected equally. Gram-negative bacteria, H. influenza is the most common. Mixture of phases microscopically and more complications. Now compare with the lobar pneumonia. All over, all the alveoli are showing just one uniform gray hepatization. Morphologically, it is one lobe affected. This is usually a primary pneumonia in an otherwise healthy adult. Males more common middle age, and the organisms are gram-positive Streptococcus pneumoniae commonest. Only one phase at any one time and usually less complications. So lobar pneumonia, community acquired, bronchopneumonia, hospital acquired. Not necessarily 100%. Remember this, okay? Commonly, that's all I'm talking about. Now, other less common pneumonias. Community acquired viral pneumonia. Although it's clinically more common, it can be asymptomatic, and severe pneumonia is not common. Picture of an influenza patient with a severe bronchopneumonia pattern, but microscopically only alveolar wall inflamed, interstitial. And although there is no consolidation, because of the thickening of the alveolar wall, patients cannot absorb oxygen. So there will be severe dyspnea. Influenza A and B, a RNA virus, has two special antigens, hemagglutinin H and neuraminidase N antigens, and there are many subtypes, and usually it occurs in epidemics, pandemics, and seasonal variations. Community acquired viral pneumonias can also be caused by other viruses, respiratory syncytial virus, adenovirus, etc. Now, briefly, atypical mycoplasma pneumonia, usually occurring in young age, children more than 3 years and young adults, a slow onset of fever, headache, malaise, and usually more than 3 days to weeks. Unlike typical pneumonia, it is days, here it is weeks. And because the inflammation is limited to the alveolar wall and no fluid or edema, the cough is dry, non-productive, and there will be maximum dyspnea but minimum signs. X-ray appears almost clear, only curly A, curly B lines here because of the alveolar wall thickening. Wheezing is common, unlike bacterial typical pneumonia. So there are many atypical features, so that's why these are also known as atypical pneumonia. Mycoplasma is the commonest, but it can be caused by other viral disorders. Now, briefly, chronic pneumonias: fungal, mycobacterial, tuberculosis, and atypical mycobacteria. Chronic destructive fibrosis, cavity or abscess goes on for months to years. There are no classic stages as in typical pneumonia. Chronic inflammation, lymphocytic, with granulomas and fibrosis, and there are many causes. But remember, tuberculosis and your self-study tuberculosis is important for this week. We are not covering, but you have to read because it has been covered in earlier years. Atypical mycobacterial pneumonias: histoplasma, aspergillosis, actinomyces, and candidiasis. Just a brief, 1 or 2 lines. Non-infective pneumonias, wherein infection is not the primary thing, that is aspiration pneumonia, usually lower lobes. Secondary infection can occur. Lipid or lipoid pneumonia is due to airway obstruction, atelectasis, and necrosis of tissue with the fat deposits from the dead tissue. Eosinophilic pneumonia, that is in hypereosinophilic syndromes, asthma, Loeffler syndrome, wherein the eosinophils are so much that it looks like pneumonia. Bronchiolitis obliterans, organizing pneumonia. BOOP, reactive due to irritants, gas inhalations, marked hyperplasia of type 2 pneumocytes, which fill the whole alveolar lumen. So it looks like pneumonia. Morphology of common bacteria, how they look like, is important. We use this in the exams. Streptococcus pyogenes, gram-positive cocci in chains. H. influenza is a gram-negative bacilli. Streptococcus pneumonia is a diplococcus, gram-positive. And here is a 2 mixture of H. influenza and staph, gram-positive cocci in clusters. Staph aureus. So just a brief about some morphology. And also hemolysis on blood agar plate. Alpha is partial digestion of blood, giving rise to dark greenish pigment, alpha hemolysis, partial. Beta is complete hemolysis, making surrounding blood transparent. And gamma is no hemolysis. The bacteria are not digesting blood. Now, the common organisms: Klebsiella pneumonia, that is the bronchopneumonia, gram-negative, is gamma hemolysis. Bright hemolysis is Staph aureus, but also we studied acute rheumatic fever. Group A, beta hemolytic streptococci, is also bright beta hemolysis. And in case of lobar pneumonia, it is alpha hemolysis. So it is dark streptococcus pneumonia. Okay, so summary of 3 morphological types of pneumonia, that is the lobar pneumonia, one of the lobe affected; bronchopneumonia, bilateral, patchy; interstitial pneumonia, only interstitial inflammation of the alveolar walls without consolidation. Although I'm showing a very characteristic chest X-ray, many times chest X-ray can be just normal. Lobar pneumonia, the commonest community acquired. Streptococcus pneumoniae, better prognosis. Bronchopneumonia, H. influenza, sick people, poor prognosis. And interstitial pneumonia is an atypical pneumonia, commonest is mycoplasma and also viral infection. Okay, thank you.